Hello, I'm Laura Machin. I'm a senior lecturer in medical ethics at Lancaster Medical School at Lancaster in the UK. I am a social science trained by background. I am a qualitative researcher and I conduct research into all forms of donation for a variety of purposes. And I like to try and focus on the people, the policy and the process surrounding different forms of donation. I'd like to thank the Donor Research Network for inviting me to present as part of their week of talks. I was flattered to be asked, and I'd particularly like to thank Barbara and Mel. Today I'm going to present Work in Progress, exploring the recent introduction of the deemed consent policy in the UK and looking at the perceived ethical uncertainties for those doctors and nurses working on the front line. There's very much a problem-solution narrative that exists around deceased organ donation in the UK, and this is in the published literature. The problems range from the numbers of patients needing a transplant are rising, so the transplant list is increasing. There are fewer people signing up to the register, and the refusal rates for organ donation from relatives is deemed to be quite high. At the same time, organ donation is presented as a moral good. It's a cost-effective method, it improves lives, and is therefore supported by the public. So the solution is presented as needing to increase the amount of organ donors available. And to achieve this, a new policy has been introduced recently in the UK, which is called deemed consent. And as a result, people will be deemed to have agreed to donate their organs after their death unless they register their decision to opt out on the NHS organ donation register. So deemed consent for deceased organ donation was first introduced in Wales in 2015, and then England last year, and then more recently Scotland this year. A soft opt-out, however, is actually deemed to what exists in practice. So families are expected to support the donation decision made by their relative in life, although they can still override this decision. It's what's called a family veto, and this family veto, however, has no legal basis. In June 2021, NHS Blood and Transplant launched a new strategy, and deemed consent was at the heart of this new strategy, and in order to help meet their strategic objectives by 2030. A number of protections have been incorporated into this deemed consent policy, and I think it's noteworthy that the public are perceived to be requiring some form of protection from the policy. Two of these protections can be categorised as the opt-out option, and the assumption with an opt-out option is that actually an individual opposed to organ donation is more likely to opt out under a system of presumed consent than someone who desires to donate is to actually opt in under an explicit consent system. The family input is deemed another form of protection. The idea is that the relatives have supposedly insider information and are from the relative, the deceased relative, and therefore they play a role in upholding the deceased person's wishes. Also, in practice, fewer families are less likely to override a deceased wishes in an opt-out system, and as a result, a deceased person's autonomy is increased. It is, however, quite a complicated picture, deemed consent. It's not actually that straightforward. Many of the criticisms put towards an opt-out system are similar to those that are put towards an opt-in system. These are just a few here. Getting people to register their intentions, for example. Having difficulty overriding the family. How informed is the consent that's actually given for the donation to go ahead? And whether the organs will actually continue to be gifted. And ultimately, it can all lead to tensions between healthcare practitioners and the families involved. It's also further complicated by the support for a deemed consent policy. is actually quite variable. In the past, there's been high-profile support from prime ministers, from the British Medical Association Ethics Department and the Chief Medical Officer, as well as patient groups. However, interestingly, there's been resistance and a desire to focus on educating the public instead. And raising awareness so that the families themselves are likely to decline less frequently. Others have actually claimed that donation should become an end-of-life choice, and instead we should actually be acknowledging the legitimate role of families involved in the decision making. In addition to this, the success of opt-out policies, again, is quite limited. For opt-out countries have some of the highest and lowest organ donation rates. And there's a range of reasons for why that might be the case. Equally, countries without opt-out legislation have secured increasing donation rates after actually implementing changes in the infrastructure around donation. Many of the debates in the published literature implicitly and explicitly question the ethics of deemed consent. So just how ethical is a deemed consent system? Can consent really be deemed? I think this is reflected in the language and the terminology in the literature around the policy. Many various terms have been tried and tested, so equally not always quite fitting and capturing what is actually going on. There's concerns that the silence can be equated to tacit consent. People who are indifferent to donation become donors by default. And ultimately, it really is challenging our common understandings of consent when it's thought to be something that's quite an active process and something that is given explicitly. This has led to some querying how ethical a deemed consent system is. Do people really have the ability to opt out? There's concerns here over language barriers, maybe those that have got a cognitive impairment, whether people have got access to an internet or a computer, or even whether they just simply have knowledge of the policy at all. So how informed are the donors? And does this really matter? Does someone sign up for whatever donation entails? Or can they refuse particular parts of the treatment necessary in order for the donation to go ahead? Some have argued that actually donation is about values and simply doing something that is acceptable. Staff therefore need to be reassured that when they are supporting donors, values when they try and promote donation practices or engaging in donation practices. A deemed consent system has also created worry over who owns a person's body. Who decides what happens to a person's body when they have died? There's questions whether the family really owns their body of their deceased loved ones. And parallels have been drawn to other forms of donation, such as whole body donation, where the family veto is excluded. There's been concerns that the state own a deceased person's body. And again, a comparison is drawn with the retention of tissue during a coroner's post-mortem, whereby consent is not required, as it may be required to establish the cause of death. Others have claimed that actually a deemed consent is going to have a positive impact on body ownership and actually require an individual who wants to opt out to make it their responsibility for what they want to happen with their body when they die. I think it's interesting here that the Welsh Assembly has chosen a soft opt-out to highlight that the state will not go against family wishes and thereby avoiding the perception of the state as acting as though it has the right to the organs and provoking lots of opt-outs from the public. There's many debates in the published literature which really pitch the needs of the living versus the needs of the dead. And the living in this instance are the doctors and relieving them of the burden of having to ask grieving families for permission for organ donation to go ahead. Apparently it avoids additional strain on relatives, although others have actually questioned whether it's actually possible to reduce the families' emotions at the stage of the request. And these needs are all pitched against the rights of the dead, arguably to non-interference. self-determination and autonomy. It appears that there's much uncertainty surrounding how ethical a deemed consent is as a policy then. When considering uncertainty in body donation, researchers are encouraged to consider why healthcare professionals are drawing attention to the uncertainty. What is happening? What is being achieved? And ultimately, what is at risk? So if we apply this to organ donation and the deemed consent policy, are healthcare professionals questioning what is morally acceptable and what constitutes ethical practice in organ donation? Walker claims that morality is something we do to account to each other for our identities, our relationships, and the values that define our responsibilities. Verkerk sums this up nicely and says, when she says it is a way of expressing who we are, of understanding others and holding others and ourselves to moral account. As researchers then, can we glean healthcare professionals' values and principles relating to deceased organ donation by focusing on the ethical uncertainties identified by healthcare professionals? So today, given the recent introduction of deemed consent to England and Scotland and the new strategy document for organ donation from NHSBT, it is timely to reflect on healthcare professionals' perspectives on the deemed consent policy and in particular the opt-out and the family veto aspects of the process. I'm going to present emerging findings based on 24 in-depth semi-structured interviews, which were conducted at 2013 at a time when Wales had agreed to move to deemed consent, which would then be introduced in 2015. The ideas were being pushed and mooted for England during the time of the interviews. And these interviews took place with clinicians and nurses across 3 wards in one NHS trust in the northwest of England. I've conducted an initial thematic coding of the interview transcripts and focused on 5 linked questions, all relating to certainty or uncertainty. The study itself received research ethics approval, and really what I'm hoping to present today is initial observations. In particular, I'm curious to see if a donation ethics is emerging from the interviews. In this instance here, the first uncertainty was surrounding how the deemed consent system would work in practice. Participants were concerned that the system would equate to a loss of consent, whereby consent is deemed active and explicit. They create negative, significant consequences. They use dramatic language, and the examples are on a large scale. Participants position themselves implicitly as concerned about the donor system continuing, and the medical profession generally. By doing so, participants position themselves as both in favour of organ donation as a practice, but also as in support of and on the side of donors, relatives and society. Implicit in the extracts is a preference for healthcare professionals to work collaboratively with relatives and donors and non-donors. You see it there in the extract, taking their organs no matter what you say. In turn, perceived loss of consent in a deemed consent system implicitly position healthcare professionals as valuing democracy rather than operating by national policy and being told what to do. Healthcare practitioners have a desire to uphold people's autonomy over their bodies in a donation system, as well as retaining their clinical autonomy over their practices. Another uncertainty was generated by participants around the logistics of opting out. The participants used tempered language, but the tone shifted and became assertive when discussing the need to ensure people could not become a donor. A desire was expressed by healthcare professionals for fairness within a donation system. Again, a preference for democracy where people are not told what to do with their bodies or healthcare professionals how to do their job. Essentially, there is an equaling of power in the donation system between the state, the healthcare professionals, the relatives, and the donors and the non-donors. Participants portray themselves as quite vulnerable to national policy, something being imposed upon them. They attempt to undermine the policy by casting doubt over how well thought through it is, and they position themselves as vulnerable as a consequence, as they are the ones who have to conduct their practice according to the policy. Equally, the healthcare professionals position themselves as guardians and protectors of the donors and non-donors, and in order to achieve this, donors and non-donors are implied to be made vulnerable by the policy as well. Participants align themselves with donors and non-donors and become their champions by raising concerns over the ability to opt out, and by doing so, present themselves as valuing people, being enabled in their decision and promoting choice with regard to their bodies. Participants also attempt to set out everyday examples rather than the extreme, to imply a sense of increased likelihood of it happening. They draw on common stereotypes that can exist around the elderly to reinforce the idea of people as vulnerable surrounding organ donation, which is continued by the choice of language used to describe the retrieval of organs. The word harvest is used in these extracts. And the need for people to be protected from the policy. We see it here with the use of fail-safe. Uncertainty is also constructed by the possibility for mistakes to take place, people's organs being removed when they didn't choose for that to happen to their bodies. Healthcare professionals present themselves as supportive of organ donation and deem consent, but they generate uncertainty around how it is implemented in practice, which positions them as having little control over the policy in practice. In many ways, participants attempted to be both in favour and yet distance themselves from the policy at the same time. They also created doubt over how ethical the policy was, and in turn implied that their concerns were coming from an ethical standpoint, therefore positioning themselves as having integrity. Another uncertainty stemmed from organs being retrieved from people who may not wish to donate. At times, the opt-out function is presented as attempting to avoid this from happening, and yet doubt is created by referring to the process of opting out and/or somebody's ability to opt out. The opt-out process is described by participants as needing to be transparent and accessible to all. Such standards are implied as ensuring that donation is voluntary, despite the deemed consent policy, and people are not coerced into donating. In turn, the participants pose a dilemma inasmuch as they may never know a donor or non-donor's wish relating to how they wish for their bodies to be treated in death. Participants use language that question the authenticity of a donor or non-donor's actions or inactions. You see it here in the extracts, true wishes, genuinely consented. The doubt constructed surrounding the authenticity of a person's wishes generates a subtle vulnerability around the healthcare practitioners, as they may find themselves in a situation unbeknownst to them when they are acting against a person's unreported and undocumented when living wishes. Healthcare professionals thereby portray themselves as having an active regard for another person's welfare and therefore demonstrate their compassion for their patients. There was uncertainty around the opt-out function and is actually having limited success due to people not engaging with the deemed consent policy. In this instance, people are set up as a source of uncertainty for healthcare practitioners. The participants achieve this by showing insight into the public's decision-making behaviour. The deemed consent policy then is presented as having the potential to generate more donors and therefore fulfil its aim, although the healthcare professionals subtly cast doubt over how ethical the means are in order to create the additional donors needed to meet transplant demand. The concern for the ethics of a deemed consent policy is further reinforced by the sense of a dilemma for healthcare practitioners. The tricky situations is one such example in the extracts, suggesting that the policy, if not straightforward. Essentially, participants present themselves as concerned over bodily autonomy when discussing people's lack of engagement around opting out, and society is vulnerable in the face of a deemed consent system, i.e. not having organs removed, that they may not have chosen to do so if it was an opt-in system for organ donation. This enables healthcare practitioners to highlight their compassion for donors and non-donors, as well as their desire to act with integrity when engaging with patients, their bodies, and organ donation practices. Another area of uncertainty is how informed are people's decisions to become a donor. Participants presented themselves as supportive of a deemed consent system in principle, as they perceived it would increase the number of donors and raise awareness of organ donation practices. However, their support for a deemed consent system was dependent upon the information available to society, which in turn influenced people's decisions to be a donor or not. For these healthcare practitioners, whether a person chose to donate or not was of lesser importance over the decision of being informed. The healthcare professionals prioritised public knowledge and understanding of the realities of organ donation practices over the aim of generating more donors. The participants cast doubt over how informed the consent is to be a donor by suggesting information is withheld from relatives and the public, although it is couched within the moral good of increasing donors, donations and transplants. Throughout the quotes, there is a desire for donors to be acquired through ethical means, and to do otherwise means harms can result for donors and their relatives. Providing insight into the organ donation practices was depicted as empowering donors and non-donors in their decision making and choices, and minimising harms for the relatives of the donors. Healthcare practitioners championed the public's right to information of organ donation and valued an openness around the realities of organ retrieval practices. Equally, the opt-out system could be considered ethical if people were appropriately informed. The family veto was discussed in the context of people who have not opted out and are therefore deemed to have agreed to donate their organs. The ability for families to be involved in the organ donation decision-making process was presented by some participants as creating an ethical certainty. On the one hand, the deemed consent system was portrayed as no different in practice than an opt-in system. In a sense, all the challenges that the family veto presented for an opt-in system therefore could be applied and considered relevant to an opt-out system. On the other hand, this created an uncertainty for some participants as to why the deemed consent system should be implemented at all. It therefore implicitly undermined the effectiveness of the proposed deemed consent system, whilst also portraying relatives as in a powerful and influential position in the face of a national policy. Alongside the possibility of potential donors' wishes not being adhered to by relatives, it can be inferred that a clinician's autonomy and judgment were also stifled by the family veto. It is apparent then that participants valued autonomy and were mindful of the power dynamics that existed within organ donation decision making. But who is the family? There was further uncertainty around the family veto when the notion of the family, of what constitutes a family, was complicated. The family is implied to be an unwieldy body here in this interview extract, involving an excessive amount of people. The depiction of the family veto as a safeguard in the introduction of the new deemed consent policy for deceased organ donation is undermined and generates the impression of the deceased as vulnerable and exposed to the whims of the family. The family, once again, are presented as both powerful and a cause of potential conflict for healthcare professionals. Such questioning around the potential inclusion of extended family in organ donation decision making enables the participants to portray themselves as having the ability to make fitting judgments and a desire to make decisions without being unduly influenced by external factors. In one sense, this uncertainty around what makes a family challenges the power of the family. It casts doubt over whether they should play such a significant role in organ donation decision making. Yet there is also empathy from the participants towards the relatives and the circumstances they find themselves in, thereby enabling healthcare professionals to present themselves as compassionate. Within the extract, the healthcare professional implicitly expresses a desire to be fair and respect the appropriate family views and opinions, whilst also attempting to respect the patient's confidentiality. This achieves two things for the healthcare professional. It generates a sense of trustworthiness around their character and conduct, whilst also moving the healthcare professional into a powerful position, i.e., which family members the healthcare professional decides to include in the organ donation decision-making process to share confidential information with, whilst also reinstating the healthcare professional's clinical autonomy and reaffirming their clinical judgment. So whose wishes should be considered? Participants created uncertainty over whether a patient wishes to donate their organs or not. They did this by referring to relatives disagreeing around what a patient's wish actually was, and when family deny organ donation, despite the deceased not opting out of the deemed consent system. This enables participants to align themselves with their patients and portraying themselves as respecting patients' bodily autonomy and championing patient choice. Participants reinforce their position by framing the decision to donate as a rights issue and by using language such as choice and respect. The strength of such language acts as implicit justification for the feelings of relatives being a lower priority compared to an individual patient's bodily autonomy. Whilst there was a respect for the deceased being part of a wider community, i.e. a family, it was apparent that healthcare professionals also held the view of the deceased as individuals, and their decisions should be upheld. It is noteworthy that the family veto was overwhelming, discussed in the context of trying to facilitate organ donation and relatives refusing donation. Furthermore, participants provide examples where a dying or deceased person's decision is respected and families cannot overturn it, generating doubt as to why it is permitted in organ donation practices. Again, the theme of power emerges with deceased patients as vulnerable to the feelings and wishes of relatives, the relatives as the most powerful, and the healthcare professionals as guardians of the dying or deceased patient, and their role to facilitate the deceased patient's wishes to donate organs. There was also uncertainty created around how successful the policy would actually be in practice. The family veto, societal culture surrounding death and bodily ownership, and the culture surrounding the act of donation were all depicted as hindering the potential success of the deemed consent policy. These perceived restrictions were implied to be rigid and immovable. You can see it here in the extracts of "I can't see how" and "no further forward." Alternatively, healthcare professionals accepted that the policy may lead to an increase in the number of donations, but its possible success was undermined by lacking justification by references to the intangible costs to the culture of donation. Participants portray themselves as frustrated and therefore imply that they are supportive of organ donation and increasing donors, whilst also demonstrating insight into the family perspective and their involvement in organ donation decision making. The family are again presented as powerful and incredibly influential in organ donation decision making. In one way, this power is justified by references to societal perceptions of bodily ownership resting with relatives of the deceased. Yet the power is also presented negatively as a possible cause for conflict between healthcare professionals and family. In both instances, the deemed consent policy is implied as having either negative consequences, battles and state ownership, or simply ineffective and unwarranted in the face of the family veto. For these healthcare professionals, they are able to portray themselves as concerned about body ownership and valuing the voluntary nature of organ donation, which appears lost in the face of deemed consent and family veto. So in this presentation, I've highlighted numerous ethical uncertainties within the interviews. It's enabled aspects of the deemed consent policy to be called into question really as to how ethical and moral it is. Ultimately, it's allowed healthcare professionals to position themselves as ethical and as moral. And as such, I'm wondering whether a donation ethics is being witnessed and observed in the interview transcripts. An ethical framework, perhaps, that can be observed that surrounds deceased organ donation practices. These values, principles, and virtues may help to inform a donation ethics. Essentially, it is what healthcare professionals constitute ethical practice in organ donation, what healthcare professionals consider morally acceptable in practice. It may be useful, such as donation ethics may be useful for organ donation committees within trusts, or for the newly ethics forum proposed in the new NHS-BT strategy. Yet there are still many unknowns. Are these donation ethics personal and individualised, as we've discussed elsewhere about the need for a conscientious objection to be extended to some organ donation practices? Or are these values, principles and morals generic, universal, that apply to all in deceased organ donation, such as those that we can be identified for medical ethics perhaps, or research ethics? As such, further research is needed as to whether healthcare professionals' moral doubts and ethical uncertainties have been addressed or resolved since the deemed consent policy has been introduced. Thank you very much for listening. I really do look forward to receiving your comments and feedback and thoughts during the Q&A. And as I said, this is very much a work in progress. It's the first time I've presented it, so I'm looking forward to you engaging with it. Some of the themes I've presented, some of the ideas to help me develop my thinking even further. Thank you very much. Bye-bye.